as the president of the Sri Lanka College of Internal Medicine, let me welcome you all to this webinar this evening. As we all know, since the spike of COVID-19 cases since the last week of April, all our hospitals are quite full of COVID-19 patients. We have patients not only in COVID-19 designated centers, but we have patients in other hospitals, sentinel hospitals, and even in base hospitals. So I think it's timely that we discuss the management of these patients. And one thing which we have observed in this third wave is that a significant proportion of patients need oxygen. And close to about 15 to 20% of patients need oxygen. So the proper oxygenation strategies is crucial to treating these patients well. So we have chosen a speaker who has had many years of experience in the acute setup. And I now cordially invite Dr. Krishantha Jayasekara, specialist in internal medicine in the teaching hospital Karapitiya, to deliver his talk on the management of hypoxic COVID patients. Over to you, Krishantha.
I think it was a timely move, and I really want to thank Dr. Harsha Satish Chandra for organizing this timely topic, and also Dr. Priyamala Jayasekara. So without further ado, shall we start the topic? This is actually a practical approach to oxygen therapy in COVID patients. Now, first of all, I will start with a case scenario. A 34-year-old previously healthy male who had fever and sore throat 3 days and was diagnosed as COVID-19 following PCR testing and was transferred to ICC. Actually, it is lucky to get a bed in ICC. His saturation dropped to 94 on day 2 and was transferred to a teaching hospital Karapitiya, as there were no vacant beds in designated COVID treatment centers. On arrival, he was afebrile with a respiratory rate of 26, sets of 92 with bilateral crepitations, and his pulse was 96, blood pressure was 130/80. He was directly admitted to isolation designated ward for COVID. And now my first question is, how do you categorize his disease? Next question is, what is your initial respiratory support? Now we do have 5 categories of disease, and this patient falls into a moderate disease category, where this patient with a respiratory rate of 26 and a saturation of 92. So he falls into the category of moderate disease. So now next question is, how do you manage his hypoxia in this disease category of patients? Now there are multiple modes of oxygen delivery. Conventional oxygen therapy is what we are very familiar with, and now which is coming up is high flow nasal oxygen, which I will be elaborating later, the practical aspects. We do have CPAP, which most of the medical consultants, trainees are familiar with. Then for patients who are CO2 retaining, we put them on BiPAP, that is non-invasive ventilation. And then we have mechanical ventilation, which we are not very much experienced. Now, conventional oxygen therapy would be my first choice to start this patient on. And then there are various devices that we use. We have low flow devices, a nasal cannula, simple face mask, or what we call a non-rebreather mask. And then you have Venturi mask and high flow nasal oxygen as high flow devices. Now, we need to know the relationship between the flow rate and the FiO2, because some of the denominators have TF ratios, and then you need to know what FiO2 your patient is on. Usually we have now say for somebody who is on 2 liters, we take it as 28%. So 4% per each liter rise is the usual calibration for you to make your life easy. For instance, somebody who is in 10 liters, we call it 60% of FiO2. So this you need to know. Then you need to know also what we call a PF ratio, that is partial pressure of oxygen to FiO2. Usually somebody who is breathing FiO2 of 21%, his PO2 is around 60 to 100. So it's about 3 to 5. And if somebody is breathing 60% FiO2, his PO2 should be 180 to 300. Why we need this is, if you know this, you don't need to disconnect a patient from a source of oxygen when you want to do a blood gas. So this is quite important. Standard abbreviations are very important. We call N as nasal cannula, we call SM as simple face mask, and RM as reservoir mask. So I will show you now each and every one of these now. So in a nasal cannula, you deliver about 1 to 4 liters. That is about 24 to 36%. This is very comfortable for patients who are needing low flow of oxygen. Simple face mask is a device that we use very often for patients who need a higher concentration, and we start at a flow rate more than 5 and maximum is 10 liters. So you need to make sure that you give at least 5 liters and you don't give more than 10 liters to a simple face mask. Venturi devices are important, especially when you want to give fixed amount of oxygen for people with CO2 retention, which is a minority of patients with COVID these days. And the other important device that you need to know is the non-rebreather mask, which is we call as RM, reservoir mask, right? So this if a patient is not achieving the target with the 10 liters of simple phase SM, you will put them onto a non-rebreather mask. You can start with 15 liters, you can come down to 10, but if your targets are achieved at 10, if the patient is comfortable, you can always change your mask to a simple face mask when the flow rate is less than 10 liters. So the other practical aspect is before putting these should be ideally a disposable, but we reuse them, and there should be a valve with the reservoir bag, and you need to push this valve till the bag is at least 2/3 full before you putting this mask to the patient. Now this is nowadays we have very limited access to documents to the COVID area. So it's very important that we use standard abbreviations for oxygen. Now say this is a patient's progress chart of now say you day 1, patient A was on 8 liter simple face mask. So his oxygen requirement had gone up gradually. Now day 3 is on 15 liters rebreather mask. He had to be changed into high flow on day 4, and then he had to move to HDU for NIV. So this sort of abbreviated chart is very important when you manage multiple patients in a ward setting with COVID needing oxygen. If you look at patient B was started on 6 liters simple face mask, then was weaned off to 4 liters nasal prawns. Next day 2 liters, the patient was comfortable, weaned off, and then sent to level 1 center. So likewise, you can always document these in standard abbreviations, and this sort of a chart is very important to monitor the progression of a disease of COVID patients, because we don't have the documents. Usually the documentation is away from a positive area, so it's not at the same place. So you need to use a lot of abbreviations, but that should not influence the patient's daily status and the disease progression. Principles of starting any sort of starting oxygen therapy is if the patient is in a respiratory distress with a very high respiratory rate, low saturation, we always go for a non-rebreather mask. But if the patient does not fall into this category, we put them onto what we see whether they are possible candidates of CO2 retention. If that is not the case, we put them on either face mask oxygen or nasal cannula. If there is a risk, we put them on ventilator. So this is a standard of care for oxygen delivery in any sort of patients. Now we'll go back to our patients who had a respiratory rate of 26. His tidal volume was around 500, presumed to be around 500. So his minute volume is 13 liters. So if you give 4 liters via nasal prawns, we will only be giving 25% of his minute volume. But reasonable amount is around 50% of your minute volume. So we can start this patient on 6 liters simple mask SA. So we can, if the patient is very, very unwell, we will start with 15 liters where you can give 100% of your presumed minute volume. Now, how would you monitor oxygen therapy? You monitor your respiratory rate, you monitor your saturation, and you monitor your work of breathing. Now, you repeat ABG only in patients with CO2 retention. Now, you don't need to repeat ABG on patients that I have discussed where the oxygen requirement is very low and the patient is improving, and then you can go by the other parameters, respiratory rate, saturation, without a blood gas. But if a patient is deteriorating, or if the patient's oxygen requirement is increasing, or if there is evidence of CO2 retention, you might need to repeat the blood gases. And also, if you step up the oxygen, so do not step it up sequentially and wait for 5 minutes with each step. So presume you start with 6 liters, you increase to 8 liters, wait to at least 5 to 10 minutes to see whether the patient is responding, and then you step up to 10 liters. So wait at least 5 liters per concentration rather than stepping up. And also you need to also think about weaning these patients off oxygen, because we might shortfall of oxygen in the future with the way the patients are flowing in. Now, go back to the scenario. You start with the patient on 6 liters simple face mask, and doctor on admission had done a blood gas on oxygen, which shows that the patient has improved quite nicely. And then after that, you monitored the patient with the saturation, work of breathing, and the saturation picked up to 98% within 10 minutes, and the patient's vitals stabilized for 1 hour. Now we need to think of weaning these patients off oxygen. So there are protocols to wean. Now this patient whom we started on simple face mask on 6 liters, we can put the patient to nasal cannula, 4 liters, and then monitor him for further 4 hours and see whether the parameters are stable. Then we can wean the patient after 2 liters. Likewise, we can do a gradual weaning. This will save oxygen. At the same time, if your patient is not improving, you need to step up oxygen depending on the patient's saturation and work of breathing. You might go up to 10 liters and then change over to non-rebreather mask likewise. So you need to step it up as well. Now, the other important thing that we actually have proven to be effective is proning, awake proning. Now, proning was very widely used in mechanically ventilated ARDS patients, but it's now becoming quite beneficial in conscious patients requiring oxygen. So it improves oxygenation, it reduces the need of ventilation, and actually it even reduces mortality. So this has to be employed in patients with disease severity moderate or above, and you need to train your staff, and you need to make sure that the patients are prone as much as possible. So there are various guidelines and criteria on this, what I have just shown you, what we practice here. So if the patient is on more than 28% of FiO2 to maintain saturation above 92, we put them on awake proning. And it needs a little bit of nursing care, support from the patient, and you need to educate the patient. And patients, so it's not going to be comfortable for the patient, but it's going to be definitely effective because it recruits the collapsed alveoli in an awake patient. Now there is a protocol that we follow, up to 2 hours of flat, fully prone, then semi-prone, likewise, then prop up, then again to the other side, likewise you can do. But you need to, the patient has to comply with your treatment. You need to explain to them to make sure that they comply with treatment. So take-home message on conventional oxygen therapy for patients whom we discuss, similar patients coming with a moderate disease who improve with conventional oxygen therapy. So we need to know the ideal target, and this for patients with COVID, it should be 94%. And we know oxygen is a prescribed medicine, and we need to document the flow rate and the device and the target. So the target should be 94%, and SM is for simple mask, and 6 liters is the flow rate that we would initially start with. And we need to know the stepping up and stepping down, weaning off. And we also need to make sure that the patients are continuing on other conventional therapies, which I will be describing later, including awake proning. And also you need to make sure that you don't delay the next level of respiratory support if your patient is not responding to conventional oxygen. So I will be next moving on to high flow nasal oxygen and NIV, which would be the limelight of today's talk in COVID pneumonia. Now, again, start with the case scenario: a 54-year-old confirmed COVID pneumonia receiving 15 liters of reservoir mask oxygen on a level 2 facility. And the registrar is concerned since the saturation is persistently ranging around 88 to 90 and 86 to 88, and the work of breathing is increasing. So the registrar has done a blood gas which shows type 1 respiratory failure. And you are concerned and you decide to shift the patient to high dependency unit. Now, your next decision as the managing physician, actually the HDU is also being looked after by a physician. So whether you should put them on a sort of a non-invasive strategy or should you mechanically ventilate them. So this was the initial study that was done in Wuhan, where on mechanically ventilated patients, and it was quite disappointing that more than 50% of the ventilators patients succumb. So they subsequently, I think the world understood mechanical ventilation would not be the best mode of therapy in COVID pneumonia. So non-invasive strategies. Now we have high flow nasal oxygen, we have CPAP, BiPAP, both we will be talking as NIV. Now this is the strict national guidelines published by Ministry of Health and Epidemiology Unit and with the other professional colleges. And this clearly says that if the patient with saturation of less than 92 with increased work of breathing will need to be initially tried on CPAP, high flow or NIV. And if the patient's work of breathing is normal, they could be managed with conventional oxygen. So it's even in the national guidelines, they mention that we have to start non-invasive strategies first. So the NIV initially was thought to be risky to the staff because of the aerosol generation, but subsequently with the understanding of the pathophysiology and the problems with mechanical ventilation and the resource strains, they identified NIV and high flow nasal oxygen are a couple of main stages of therapy for managing hypoxia in patients. Now, for instances, countries like us where the resources are restricted and I think everybody is aware that the ICU is nearly full now or almost fully occupied, and we have a lot of patients needing respiratory support, makeshift units managed by physicians. So we need to know, and especially when the resource constraint setting, how to manage these patients on these devices. I will first touch on CPAP and NIV, where we are familiar because we have NIV machines in most of the medical units, and we put them for patients like pulmonary edema and COPD. But we have not used these devices on COVID patients. Now, what is the evidence? I will not go into, because since this is practical, I will not go much onto the evidence, but there is enough evidence that the NIV is beneficial and it reduces intubation and it improves mortality as well, right? So a lot of clinical trials are coming up and have been proven that NIV is quite beneficial. You need to, now interface is the mask that you're going to use. So you need to have a seal system because this is a aerosol generating procedure and you need to look after the safety of the staff. But now other thing is I will show you later, the ward NIV machines are single limb machines, and we were using vented mask because the expiratory air was going out of the face mask into the surrounding environment. So this is going to be risky. Ideally, you need a helmet interface, which practically you can't find. So, and then we need to have alternative methods of minimizing aerosol generation. Now, this, of course, you can see the difference between a high flow and an NIV, how comfortable a high flow would be, which I will be elaborating later, and how uncomfortable, non-vented NIV mask. Now, this is what I meant by a single limb. You see on your bottom right, a NIV generator with a humidifier, then a filter you have, then you have the vented mask with a single limb. Now you can see very clearly see there is leaking from the mask and which goes into the surrounding environment in a positive patient. This is considered as aerosol generation, and we need to have full PPE to manage these patients. But whereas if you use sometimes in now most of the ICUs also this now most of the ICU patients are on NIV, but they use it what we call a dual limb circuit with a non-vented. So because since there's an expiratory limb, you don't need to have a special holes for the expiratory air to leak out, and these are safe closed systems. So, but still we use full PPE, but these are safe. Now, this is one thing that we could do for a single limb, where we can use a vented, we can use a non-vented mask, and you have an exhalational port distal to the filter. So you see on the bottom of the tubing, you have exhale. So exhalation, it's only exhales from the bottom, but it's after it goes up through the filter. So this is one modification that we can do. And if you compare with the picture on your left, you can see if you don't do that, these patients, the air leaks out to the environment quite easily. Now these makeshift unit, transform units are not fully sealed. And, there is a theoretical possibility that these viruses can disseminate from these places. So since these are makeshift units. Now, one of the most important things when you put NIV is a nursing care, because the nursing care should be optimal, and they should be looking after this patient very closely, not like a ventilated person. But we need to make sure that this group of staff is also well protected, right? So ideally we should need negative pressure rooms, but very few ICUs even have negative pressure rooms, and you can never imagine HDU in a medical unit to have negative pressure. So now other thing is that what we see a lot of there is redeployment of nurses from other specialties who have had very minimal exposure to these modes of therapy, and you have to be mindful of that fact as well, so that they have to have a bit of a training, but these people are redeployed because of the patient load. So you need to be little mindful when they attend to these patients. So it's ultimately the responsibility is in your hand, but you need to make sure that they monitor patients well, as well. You look after their safety. Before starting NIV, there are a few things. First thing is the indication. Now, for instance, the patient who was on a level 2 center who deteriorates on a 15-liter reservoir mask is a clear indication. Then we do ABG on entry ABG we do. Then we look for any contraindications. And then in the meantime, we try to optimize the underlying lung pathology. You give your steroids, enoxaparin, and whatever is indicated. And you set plans. What are your plans? Whether your patient is a candidate for elective intubation and mechanical ventilation, or whether this is the highest ceiling. So you need to discuss with these. If you are juniors, you need to discuss with your consultants. And of course, one thing that we usually hardly get any family here in COVID patients because they all get quarantined. And then you set your goals. What are your goals of oxygenation? What are your goals of CO2 elimination? Now, contraindications, if the patient is unable to protect airway, if there are excessive secretions, so they can aspirate. If the patient is on a couple of inotropes, if the patient is on touch of noradrenaline, that's not an absolute contraindication. Patient on 2 or 3 inotropes for hemodynamic support will be a relative contraindication. The patient is confused, agitated, and if there's upper airway obstruction or untreated pneumothorax, all these are contraindications for NIV. So you need to rule out that there are no contraindications. Then, as I discussed, you have set your plans whether this is the highest ceiling. If the patient fails on this, I will move the patient to ICU. I will decide on intubation. I will have my plan ready for intubation, right? Then you are set your goals, right? So if you are putting the patient on CPAP, you improve the oxygenation, reduction in work of breathing, respiratory rate. If you want to wash off carbon dioxide, BiPAP, so you need to make sure that the CO2 being washed off, the pH is increased, and vice versa, right? So finally, the main aim is to prevent intubation and reduce mortality. And then if you could prevent the intubation, and that is a gift at this point of time because we are really short of ICU facility. Now, there are 2 modes that we use. We use either CPAP for hypoxemic respiratory failure, and we use BiPAP where we put a pressure support as well on top of a baseline PEEP, so which is called a BiPAP, bilevel ventilation. So the recommended 2 modes in your machines, which you are familiar with, we use CPAP for hypoxemic, and then what we call a spontaneously time mode. We use ST mode for hypercapnic respiratory failure. So you prop the patient up, explain to the patient, and you select a properly fitting mask, preferably a non-vented mask. Adjust oxygen flow rate, and then hold the mask gently. After a few minutes, put on the straps, and you start with a low pressure, like 7 centimeters, and you can start work yourself up, increases the PEEP depending on the patient's response. So initially we start around 7 to 10, then we might gradually increase, but be mindful, the higher the pressures, it will be intolerable to the patient. So you need to be very gentle and mindful about aerophagia as well as the patient tolerability. Now, this is a ResMed Stellar machine that most of us are very familiar. So you have the humidifier, we remove the humidifier, we put a filter, viral filter, and then we connect the patient there, preferably a non-vented mask. Now, you need to be familiar. This is the ResMed Stellar 150 machine, but most of us have the 100 machine, but it's more or less the same. So you need to know the knowledge of these machines, and you need to know how to adjust when you fall into trouble, right? So just read on this. It's very simple, but you need to familiarize yourself with the machine that you are handling. This is the Philips machine that is available. So this also is very user-friendly, and again, more or less the same, right? So then this is the initial setting that you need to go by. So this is a pathology. It's usually you can either go for normal. Then you select your mode. If it is a CPAP, what you need to say is a PEEP only. If you select the ST mode, then you need to select the PEEP and the pressure support, that is the inspiratory pressure. So PEEP 5 plus pressure support 6 is 11 of IPAP. And then you set up your backup rate. So this is usually enough for your survival. But when there is troubleshooting, you might need to press the blue button, that is advanced. So this is little, I know if you are not very familiar, it will be little difficult, but there is no magic bullet in it. I will show some of the important facts when we handle persistent hypoxemia while on CPAP, right? So there are what you call a time TI max, trigger, rise time, fall time, mask time. So these are not magic bullet, things, but nice to know, good to know. But there are few things that you need to know when you fall into trouble. Now, this is the simple view of a Philips machine, and this is a detailed view. Now, unfortunately, both these machines, the stocks are out. And very recently, we got a new machine, which is a German machine. But hopefully, within the next couple of weeks, we will get some machines, the agents, because there are a lot of donors and people want to help, but the machines are not available at present. The important thing is, the monitoring during NIV. So there are 3 parameters that you monitor. first thing is the subjective response, whether your patient is comfortable and patient's, breathlessness is improved, subjective sensation. Then you look at the physiological response, the heart rate, respiratory rate, patient's conscious status, and the patient's type of breathing, whether the work of breathing is coming down. So those are the physiological parameters that we monitor. So we looked at the patient, we looked at the physiological parameters, then we look at the other parameters that will tell you whether, saturation and then respiratory rate we have calculated in the physiological response. Then if a patient is CO2 retaining, we'll repeat the blood gases to see or if the patient is deteriorating, we will repeat a blood gas. So these are the three parameters. The frequency of monitoring, we will not be very strict because of the risk of aerosol generation. If one is looking after, they can do 2 hourly, 4 hourly. Some of these patients who are deteriorating would need close monitoring. So that will be the the experience of the managing doctors and nursing, how often you should monitor these patients, not like in simple NIV patients on NIV with COPD exacerbation or pulmonary edema. So you need to attend to other aspects of care while on the hydration is very, very important. Then, the recommended medications are steroid, enoxaparin. And then as in conventional oxygen, you need to try awake proning. Because of the mass, you might not be able to get the full proning, but you can always try semi-proning as much as possible. And attend to their nutrition and psychological aspects as well while they are receiving oxygen via NIV mask. Now, going back to my patient, the patient was failing on 15-liter reservoir mask, started on CPAP because the patient was on hypoxemic respiratory failure. Patient's vitals were monitored. Initially, the patient did not show much of an improvement, and then the patient's work of breathing was also increasing, and patient was tolerating the mask quite well. So we decided to increase the PEEP to 10, and we increased the FiO to 60% as well. And patient very nicely controlled on this. Patient was settled and was kept on this setting for 24 hours. And then the patient's vitals were stable. We thought the patient is comfortable, respiratory rate is coming down. Patient seems, there is a smile in his face as well. We thought we should wean him off, and then we weaned him in gradually and then put the patient back onto 15-liter reservoir mask and then gradually weaned off to face mask oxygen. So this is the weaning process from a CPAP of a patient who needed a PEEP of 10. So when can you wean from CPAP, right? So check clinical parameters, check saturation, decrease it. So if you're happy with the patient's clinical improvement and if you are happy with the patient's respiratory parameters, you can decrease CPAP gradually from down to 7 to 5, and then you reduce the oxygen concentration and then keep on the minimum settings at least for 30 minutes, preferable to at least 1 hour. And then you plan to wean the patient back onto conventional oxygen. And then from that, you work yourself down depending on the patient's response. So this is the weaning process. And then we move on to troubleshooting. So this is the thing that we need to be little mindful. There are few problems that can happen when a patient might not respond to your NIV. So the commonest problem that we might encounter is persistent hypoxemia. Persistent hypercapnia will not be a major problem unless the patient is a COPD with a CO2 retention. Hypocapnia, respiratory alkalosis, confused, agitated. I will not touch on the last two. I will be touching mainly on hypoxemia. So when there is troubleshooting, there might be three aspects. One, it could be a patient-related problem. It could be a problem with the interface, that is mask or tubing. Or it could be a problem with the machine or oxygen supply. So you need to define which is contributing your hypoxemia. Interface or tubing problem. These are the most commonly encountered. Now, first thing is improperly fitting mask with excessive strap tension. And air leaks from the mask, right? So the mask might not be fitting into the facial contour of a patient. And there might be a little bit of nasal bridge trauma as well. So you need to, if that is the case, you need to adjust the mask. Then there could be machine factors, right? Patient factors are, I just skipped it because if the patient, usually the patients are, they do tolerate machines because of this scarcity of this illness. So they do tolerate quite well, not like in other illnesses, right? So there are machine factors. One thing is now we know that there is a tidal volume. So when you go back to advanced settings, or you see in the main setting, you see the tidal volume. Usually we expect around at least 6 liters per kg of a tidal volume delivered to these patients, and you need to see delivered tidal volume. If the delivered tidal volume is low, you can increase the PEEP, or you can increase the TI, right? Timed inspiration. So you increase the inspiratory time. That is where you need the advanced setting. And then if there is usually the main screen shows you the amount of leak. Usually there's a leak compensation. 10% of a tidal volume leak is acceptable. Presume that you have a 300 ml of a tidal volume and 30 ml leak is acceptable because the machine compensates for the leak. So what we call a leak compensation is always there, but inevitable. But because don't try to minimize the leak to zero, because what you will end up with a very tight mask and causing nasal or facial ulceration. Then if the patient's other thing is patient is auto triggering, the patient's spontaneous rate, it's auto triggering. So you need to change inspiratory type. And also you can, if the patient is hypoxic, if you can increase the flow rate above 15 is the one that we can give it a regular, it's a conventional regulator, but there are flow meters that you can increase the flow rate to 25 liters. So if you have that facility, use that as well. So this is what you should do when a patient is persistently hypoxemic while receiving NIV. It could be patient factors which are very little. It could be what we say is a tubing or interface factors. It could be something to do with the machine, which we need to see which one is contributing to hypoxia. So now I will be skipping on to high flow nasal oxygen therapy in COVID pneumonia. This is the one I think which we were not very familiar with. So I will be talking a little in detail about this because I think this one now we have in our wards, we do have these machines where we are now getting used to these machines. Now high flow nasal is considered to be a number of advantages. It's definitely better than conventional oxygen therapy. This was initially used in pediatric practice, and it was extensively used in pediatric practice, and very recently only it came on to adults. But with the appearance of COVID pneumonia, its use had been expanded heavily in adults. Now we use it for 4 indications. Now, commonest thing that we use is hypoxic respiratory failure that we see in COVID patients. Then hypercapnic respiratory failure, which is not very frequently used. And then also this is used very extensively in ICUs for pre-intubation oxygenation and post-extubation as well. Now we know severe COVID-19 often progresses to hypoxemic respiratory failure, and there we know that there are problems with mechanical ventilation and severe resource constraint. And NIV is both these processes cause aerosol generation, but very little with, I will show you how we could minimize aerosol generation with the high flow. Now there, again, I will not go into much of, there are plenty of evidence of high flow nasal oxygen in COVID-19, which have prevented intubation, ICU entry, and reduced mortality. And also there are a couple of studies that looked at the aerosolization, dispersion, and infection transmission. And strangely, there was no significantly increase in aerosol generalization or infection to the exposed staff with high flow. So this is quite encouraging. So this is one thing that we need to go for. Now this is a comparison between non-invasive ventilation and high flow in COVID-19, and it has shown that it is not inferior. None is superior, but it is non-inferior. There are pros and cons to each. So we need to know both these devices, because I will show you why. Right? Now these are again advantages and disadvantages of NIV and high flow nasal oxygen. The patient tolerance is very high with high flow because the cannula is very comfortable. But one problem is, if you use very high concentration of oxygen, you might deplete your oxygen storage. So this is one thing that you need to be mindful. Though people claim that there is no shortage, but with this influx, we never know. So we have to be very mindful about the level, the concentrations of oxygen we deliver. Otherwise, both are equally effective. High flow nasal oxygen, it's very easy to prone as well. These patients, not in NIV, we need to semi-prone, but with high flow, you can easily fully prone them. Awake proning is very easy with high flow nasal oxygen. Now on your left, you will not see this nice lady without a mask. So this you might not see in practice. Now this is what you will see in practice on your right. A patient on high flow with a surgical mask. So the aerosol generation can be minimized further, whereas you can't put this into a patient on NIV mask, right? So this is how you could prevent aerosol generalization or aerosolization of the management areas with the high flow nasal oxygen. Initially, this was used in ICUs, HDUs, later on in the emergency units, very extensively in pediatric wards. Now it's been moved into COVID wards. For instance, in our institute where we work, we had, when you counted these machines, we had 19 machines of high flow in the institute. I couldn't imagine. And 1/3 was in pediatric ICU. Significant amount was in pediatric units. A couple was in adult ICUs. But now, so with, I think we have come to a compromise, and some of these have been moved into where the COVID patients have been managed. So we need to know how to set this up, especially the nurses should know. But very little nursing is involved, not like high flow, but still we need to know when the patients are on high flow, how to set it up. And so there are a lot of physiological benefits. There is reduction of dead space because of the humidification and, heated. So it's very comfortable to the patient. And also it gives very high percentages of flow rates of oxygen. The device is portable device, and which comprises of a oxygen blender, heated circuit with a very comfortable cannula in the middle, and a heated humidifier. Now this is how the device look like. The machine is very handy, portable. The nasal fronts are also very comfortable. The cannulas are very comfortable to the patient, and this shows why the people are so compliant with this treatment. So I will take you through briefly how we set this about, and this is we wrote to the Fisher and Paykel machine, which we all are handling, and this is you have the humidifier, and then the tubing. You connect the tubing, and you connect on your right. You connect the nasal cannula to the tubing, and this is how, once you do that, this is how the machine looks like. And you need a source of water to the humidifier, auto filling. So what we usually use is, we don't have the set water bag, so we fill a saline with the lukewarm water and we hang it up, and then usually the humidifier automatically fills up. And there are 3 parameters that we need to adjust. It's very easy, but you need to know them. There are 3 parameters. On your left screen, you have the 3 parameters: temperature, flow rate, and FiO2. On your middle screen, you have the temperature. You can set it up from 32 to 37. Usually we set it up at 37 for it to be comfortable. But if the patient complains, we can bring it down to 34. Then the flow rate. Flow rate also we can adjust. We can start from 10. We can work ourselves up to 60 liters. But be mindful about the flow rates, that because of the problem of oxygen consumption. So with very low flow rates, like 15 liters, you can achieve your target. So then it won't waste your oxygen. Next thing, you go to the FiO2. So adjust FiO2 is a different thing. You go to the FiO2 screen and then you change it with the flow meter. So you increase the FiO2 with the flow meter. Usually we start with about 30 to 40%. Then we can go up to 60% of FiO2. Usually you don't need that much. Right? So this is how you set up your machine, and it's very easy. Now, this is one thing that the nurses should do. Once you finish with one thing I couldn't tell you is these nasal cannulas actually are disposable, but if you are using for COVID positive cohort, you can reuse them. But if you are going to use it for non-COVID, you need to discard all this tubing. But anyway, we do what we call a disinfection of after each patient. But mind you, this process takes, so it's 55 minutes. The machine takes 55 minutes. There's a special red tube that we connect these two ports. And then once we switch on the machine, it takes. So what the message I want to tell you is, now make sure that the machine, you have disinfected the machine before putting to the next patient. Because you can't put it all of a sudden, the machine will automatically say that they want to disinfect the machine. Unless you have done that after the last use, you might not be able to put you for your next patient in an emergency. These are some practical points, right? So problems with NIV and high flow, risk of viral transmission to staff and other patients, high consumption of oxygen. Some NIV needs more intense monitoring. There could be staff exhaustion, burnout, or limited experience with deployed nurses. And there is what we call this patient self-induced lung injury, is a concept that has come up. Now, this is for patients who are conscious, who are breathing rapidly. Now, there is a shear stress onto the lungs, and that can cause lung damage, right? So this is one thing that we need to be mindful to make sure the work of breathing is the parameter that will tell that there is a patient self-induced lung injury, which is called PCL, right? So now, if you look at this picture, on your left, you have what we call the low elastance type, and you can stop disease progression with non-invasive ventilation. Now, high flow, CPAP, NIV, but you need to make sure that the patient's work of breathing is not going up. If the patient's work of breathing is going up, there is going to be patient spontaneous induced lung injury, which might, with the virus, might cause more damage and end up in fibrosis and irreversibility and ending up in ECMO, right? So you need to be mindful of the fact that when the patient's work of breathing is going up and the patient's respiratory, the oxygen requirement is going up, you should get the help of the intensivist or anesthetist and then move the patient to ICU setup and then think of early intubation rather than causing more damage to the lungs. Now, but I will show you the previous slide again. Invasive mechanical ventilation has very dire consequences. So try to prevent patient going into this state. You can do that with close monitoring and appropriate oxygen delivery. Now, should we intubate early or should we intubate late? Is been the hot topic for the last year. Now, there are two schools of thought. Some people say the early intubation, but the local experience and the global experience is that the intubated patient's outcome is poor. So it all depends on how the patient's, the respiratory mechanics, whether the patient's lung injury, how the progression of the disease, and patient's self-induced lung injury, all are contributing. But I will leave it in your safe hands to prevent these patients going into this state. So thank you very much. I would be happy to answer if there are any questions. Hopefully Priyamali would sort out if there are any questions from the audience.
Yes, Krishanta, thank you. First question is Is there good quality evidence to suggest awake proning in COVID-19 non-intubated patients?
There are plenty of trials that have shown, and it's coming up in most of the guidelines as well. So I think we need to practice that. We need to put that into practice, give that benefit to the patient. So it's definitely it's proven. I didn't, because you Priyamali wanted me not to show any data, much of a data, go for practical. So I didn't get these slides, but there are plenty of evidence, and most of the, all the guidelines, they have criteria for proning, very, very light criteria. 28% FiO2 needed to maintain saturation is an indication for awake proning.
Thank you, Prashant. The next question is, it's actually an interesting question. What is the reason behind happy hypoxia? Why are the patient not much distressed with relatively low SpO2?
Yeah, the thing is, now the initial disease, we know that there is a vascular thrombosis. So because of that, because of the vascular element, there is very little effect on the alveolar gas transfer. So patient might not be feeling that hypoxia, but when the tachypnea is not there, and when you check their saturation only, you might find them hypoxic. So that is why even at level 2, level 1, we check saturation at least twice a day.
So there's another question. I think you actually answered this while doing the lecture. Is there evidence unvented mask in NIV increasing the risk of transmission to healthcare workers, or is just a hypothesis?
There is actually, there is not much. It might be a hypothesis, but it's a true fact though. We do see this when I put a patient on CPAP, I usually keep for pulmonary edema, I keep my hand to see whether there is air comes with a very high flow rate. So it definitely causes aerosol generation. There is no argument. Thing is that we manage these patients with full PPE. But the problem, Dr. Priyamali, is now the newly formulated COVID units, they don't have full protection of prevention of aerosol dispersion. So this is the risk to the outside, not to the cohorted patients and the staff who are with PPE.
Okay, thank you. There's another question. Is there any benefit of CPAP over high flow nasal oxygen? I think you answered this question.
Actually, there is, it's a preference of the managing clinician. Both are equally effective. Tolerance is quite good with high flow nasal oxygen, but the problem is if you are using very high flow rates, you might empty your oxygen reserve very soon. So this is a balance.
And there's another question. What are oxygen concentrator? There's another question with that. What is work of breathing and how to measure?
The work of breathing is a subjective measure that we look at the patient and we look at their, one thing is the respiratory rate. Other one is a pattern of breathing, whether there's a dysynchrony. We have all seen a COPD patient, how they breathe. So if a COVID patient who is healthy, breathing like a COPD patient with a dysynchrony, then with the high respiratory rate and also the saturation is going down. So we know that the patient's work of breathing is high. So it's a subjective measure, but I think with clinical experience, we all should be able to spot a patient whose work of breathing is increasing.
Yeah. So the next one is, what is the target oxygen saturation in COPD patients?
It's 88 to 92. 88 would be ideal. Even with the COVID, 88 would be taken as targeting these patients.
Okay. And I think you answered this one, but I will ask that again. Is the mortality more with early intubation or late intubation? What is the evidence say?
There are two schools of thoughts. So there is a group that they say when you do not intubate, what happens is there is a virus damage plus patients increased work of breathing causing spontaneous lung injury, both contribute to more fibrotic change, ending up with a fibrotic lung. Whereas some people say that, if you do, now the problem is you don't do HRCT very often in some of these centers. So you might be ventilating these patients with very high settings, which can also damage it can also cause that's iatrogenic lung injury. So it should be a balance. But our personal, what I haven't managed, but what we have seen is that the ventilated patients do with the lung injury, they don't do well at all in our setting.
Okay, there's another question. How do you change FiO2 in the BiPAP machine? It's not there in settings.
Yeah, it's with the flow meter. Now if with the conventional wall oxygen, it is 15 liters. But there are special flow meters that you can fix into these conventional oxygen flow meters, where you can go up to 25 liters. So depending on the flow rate, you can decide what FiO2 that you are delivering. If it is 15 liters, it is 60%, 60 to 80%. Likewise, you can with the source of oxygen that you are connected to the machine rather than the machine itself.
And the other question, I think we have already answered. If the patient is hypoxic, how do you select Hyphen SL Oxygen over NIV or vice versa?
Yeah, that's right. Yes. This is the, we are, from physicians, we are comfortable with CPAP. So we might not go for high flow because we are not very familiar. But when you get used to it, you will like it. And the patient likes it as well. But make sure that you use low flow rates because of the same fact that I have mentioned before. So my preference would be high flow nasal oxygen at a low rate. But if you have that facility, you use it. If not, go for an NIV with a non-vented mask with the exhalational port.
And it is more safer to the staff as well, as you have already explained. Okay. And there's another question. If the patient has pneumonia clinically and hypoxic, does the imaging chest X-ray and HRCT affect the management strategies?
Ooh. I didn't touch this troubled waters. But anyway, so it doesn't matter what the imaging shows, as long as you monitor the work of breathing, patient's oxygen requirement and the blood gases. There are, whether depending on the day of the illness, it matters with the progression of the disease. So in certain patients, if the disease is progressing, obviously you will have, deteriorating blood gases, increasing work of breathing, then these patients will definitely need intubation. But if even with the imaging, worse X-ray, if the parameters are good, we will still, there is no indication to intubate early. We can go with high flow or NIV.
And one before the last, actually, generally, how long a patient would be on NIV once started?
That's the destiny of the patient. But it's not very easy to wean these off. Now, we know our experiences with pulmonary edema patients, we wean their form within hours. But here it's not so, depending on the disease progression. So we know this is a progressive respiratory disease, and you go with other therapies and the oxygen, you can minimize the progression. So if you could do that, you can wean them off in 3 to 4 days, not before that. So that is what is usual our practice. But some of these patients are on a prolonged time on NIV. So it's not very easy to decide, but it's not within 48 to 72 hours.
Okay. And someone has asked, does exertional short of breath patient need to be treated with oxygen?
Yeah, this is one thing that is being done at level 1 centers, where they let them exert and see. I don't know actually whether there is an indication to be transferred out to a level 2 center. But our parameters, our guidelines all say moderate disease patients will only benefit from oxygen, not patients who desaturate on. But these are the patients who should be very closely monitored. They might need frequent monitoring, and then if their exertional saturation drops, they are going to drop their saturation to less than 94 very soon. So merely exertional drop is not an indication. Of course, these patients very close monitoring to see whether their disease is progressing.
And if the lung damage is irreversible, is there a place for ECMO?
Yes, there are criteria now for ECMO. Now, if the patient's on mechanical ventilation and if the settings are high, if they are on a H type of a lung, which is with reduced elastance, and these are candidates for ECMO. And very few centers in Sri Lanka offer ECMO. And obviously, there are other factors also, the pre-morbid status and other things also play, but there is definitely when the patient is not doing well with mechanical ventilation.
And any idea how much high-flow nasal oxygen machine would cost?
It's 1.3, the brand that I have shown you. The leftover 2 machines I got a gift from to Karapitiya. Getting down few more machines next week.
And someone answered the question of this HRCT and chest X-ray. He has told other reason of imaging. It will helpful to include or exclude other pathologies. That is actually one of the reason for doing HRCT. I think we have answered almost all the questions. And there's one question. How about this prone position in a patient with abdominal obesity?
Yeah, these are the practical problems. If they should be actually, if that is the case, if it should be semi-prone rather than fully prone, but you can cycle them up, left semi-prone, right semi-prone, propped up, or at least a minimal of 30 minutes of, now usually we advise a 2-hour full prone, but these people, we might try to convince them and get at least 30 minutes of fully prone. So we need to actually, the proning mechanics, we need to tailor-made to individual. So this would be practically difficult, but we need to try our level best to explain the patient and get their cooperation.
Okay, thank you, Krishantha. So we have answered almost all the questions, and I think if you have any other questions, Dr. Krishantha Jayasekara is in the treatment group, so you can send a WhatsApp message and probably he would answer. And let me wind up the webinar. First of all, thanking Sri Lanka Society of Internal Medicine, President and the Council for arranging that. And Dr. Krishantha Jayasekara for very interesting, very well structured practical session. The way I expected, actually I got what I expected from you, Krishantha. Thank you very much. And I would like to thank all our virtual participants. Without you, it wouldn't be a success. Thank you very much. And not least, let me thank our sponsor, Gets Pharma, especially Mr. Dilshan Fernando, who made this poster overnight. Thank you very much, Gets Pharma, for sponsorship. So thank you very much and have a very good night.